All right. Hello, everyone. Thank you all for joining today. I guess I'll start. Sorry, this is a bit awkward because I can't see you, but I know you're there. Hello, I'm Christina Chant. I am the Director of Education and Clinical Activities here at the BC Centre on Substance Use. I'm gratefully calling in from the unceded traditional and stolen territory of the Musqueam, Squamish, and Tsleil-Waututh nations. And before we get started, I'd like to honor the lands that we're calling in from today, and take a moment to also just recognize that the ongoing criminalization, institutionalization, and discrimination against people who use these drugs disproportionately harms Indigenous people, and that continuous efforts are needed to dismantle colonial systems of oppression. We see our work here at the BCCSU as connected to these efforts. And while this says ECHO, I'll just say that this extends to all education efforts that we provide, that we contribute to a system that provides safe, respectful, and evidence-based care and advances the health of Indigenous people when it comes to substance use care and other health outcomes. So just to kind of continue our welcome. So today we're going to be we're very excited actually to be providing this webinar, which is on the updates to the opioid use disorder guideline, and very excited to introduce the panel that we have who will be speaking today. And so I'm going to, before we get into that, we'll just flag a couple of items. So you can use the Q&A function and vote on questions while you're watching this webinar. I'll be moderating, and we have some kind folks in the back who are helping facilitate this webinar with Cora and Liz and Lindsay who are recording. This is a Zoom webinar, so the participants are muted and videos are disabled. And there will also be a pre and post poll, which Cora, you can launch the pre-webinar poll for us and just ask that nobody closes that. This will be up for 5 minutes. And while this is up and you are answering, I'll hand it over just for each panel member to introduce themselves. So first, I'll start with Dean.
Hello, everybody. My name is Dean Wilson. I've been a harm reduction advocate in the downtown east side for, I don't know, 30, 35 years. Once president of Vandu. Sorry. So I sued the government to constitutionally enshrined Insight, the supervised injection site. And sorry, the smoke keeps going off. I don't know what I can do here. But anyways, I'm a downtown east side activist, and I'm the peer engagement lead at the British Columbia Centre for Substance Use. And I advocate for the regulated access to any drug that person needs.
Thank you, Dean. I'll now hand it over to Paxton.
Thanks, Christina. Hi, everyone. Paxton Bach. I am an internal medicine doc by training and one of the addiction docs here at St. Paul's Hospital. I also the co-medical director with the BC Centre on Substance Use and was one of the co-chairs for the wonderful committee that was assembled to put together this guideline. Very happy to be here today. Very thankful for all of the efforts of the many contributors to this work, and just really excited to be talking about it to the world.
Thank you, Paxton. And then Emma.
Hi, everyone. My name is Emma Garrod. I'm a registered nurse and was one of the co-chairs of this guideline. I also work for the First Nations Health Authority as a clinical nurse specialist. And yeah, I'm calling in today from unceded land of the Musqueam, Squamish, and Tsleil-Waututh people. And I want to just thank everyone so much for taking the time to join us today. I was really busy last week, but when I woke up Thursday morning, I was like, oh my gosh, this guideline is live. So it's, yeah, just a huge thanks to the committee, acknowledging our other co-chair, Dr. Rupi Brar, external reviewers, and so many folks that contributed to this, and special thanks to the BCCSU medical writing team, which maybe Christina's also gonna do.
No, I'm happy to do that. And I think I'm like the Wizard of Oz right now. You can't see my face, but I'm always here No, it took it was a huge undertaking, I think, with probably about 35 members of the BCCSU staff, amongst our wonderful volunteers and partners across the province. And we probably didn't mention this in the slide deck, but this work started in 2019 and was sidetracked by the pandemic. So I'm just super excited that we're able to release it today, to talk to you about it. Please bring your questions. We'll have a Q&A section, and anything we can't answer, we can try to follow up afterwards. So I'll hand it over to Emma to get us going. Thanks so much.
Amazing. Thanks, Christina. So we are going to spend a short time together going over a lot of stuff. This guideline is huge. So we'll provide a quick overview and hopefully get to some of your questions. So today we'll be going over updated and key recommendations in the new guideline. We're going to go over these new principles of care that are now embedded in the guidelines. So we'll be going over that a little bit. Looking at strategies to prevent and manage precipitated withdrawal during a buprenorphine naloxone induction. Apply some new and updated dosing, titration, and missed dose protocols to buprenorphine naloxone, extended release buprenorphine, methadone, and SROM prescribing. And very excited about this one, applying updated take-home dosing clinical guidance for naloxone, methadone, and SROM prescribing. As Christina stated, this work started many years ago now, and we also acknowledge that practice continues to evolve. So we're presenting where we got to now with the evidence there is and all the amazing practice champions out there, and this work will continue to evolve. So in 2017, the BCCSU released the BC's first provincial guideline for the treatment of OUD, and it was the first of its kind to recommend buprenorphine as a first-line opioid agonist treatment. It also recommended slow-release oral morphine as an alternative treatment option for OUD. And it also, in that continuum of care, recommended included harm reduction services as a standard of care and foundational to the work. As we know, practice has evolved a lot since that time, and also the toxic drug supply has continued to worsen and evolve. So really knowing that we needed to update guidance for clinician practicing to meet those evolving challenges, including high opioid tolerance. We know that the toxic drug poisoning crisis continues unabated in our province. So, you know, the data continues to evolve as well and be updated, but to 2022, you know, 10,000 people have died in our province, and we all feel that. And, you know, every part of Canada has been affected by this crisis. It's also, you know, across the United States as well. But BC has seen both the highest number and highest rate of unregulated toxic drug deaths in Canada. Within BC, the Northern Health Authority had the highest rate, and Fraser Health Authority had the highest number of toxic drug deaths. And the rates in First Nations communities and individuals is also extraordinarily high. We know that we can go to the next slide here. So everyone on this call is aware of the impact of fentanyl on those rates, detected in about 3% of drug poisoning deaths in Canada in 2012, to 86% in 2021, and 81% in 2022. We also saw benzodiazepines come into the toxic drug supply, and we know that, this continues to evolve and is causing lots of harms for people, but also just this evolving supply. So fentanyl now being the most, or its analogs being the most prevalent type of opioid, which has really increased people's tolerance. And so what used to work for folks is not working anymore. And we've really needed to update what we do as clinicians and to continue to meet people's needs, so we can provide good care. So the new 2023 update, tries to incorporate all of that, the evolving evidence, the evolving practice, and the evolving experiences of people who are using drugs. So we have updated clinical recommendations and guidance on the full continuum of care for OUD. These new principles of care, which I'll talk about in a moment, they're not new, but they're now included in this guideline. Updated protocols for dosing and titration and missed doses. to sort of try and meet those increased opioid tolerance needs, the new protocols for take-home dosing, and considerations for providing care to special populations. So yeah, really, wanting to acknowledge that these principles of care are something that many providers are doing already in their practice, have been advocating for and incorporating, but it's really great to build them in as foundations to this work into the guideline. You can see here on this slide, there's a number of principles of care. We could talk about each of them for an hour, but just going to go over them really briefly. So, really wanting to build these in as the foundations, overarching principles of care to facilitate collaborative partnerships with individuals and families experiencing opioid-related harms, and really also recognize some of the contributing factors and the pieces that we know are what people are living with, and additional pieces we can do to support. So patient-centered care, shifting those power dynamics, and really recognizing individuals as experts in their own care, and respecting those unique needs, values, and preferences of each person. And I think you'll see some of the clinical guidance aligns with that, recognizing the social determinants of health, recognizing opioid use disorder being viewed within a larger society framework that's shaped by inequities in the social determinants of health, and also trying to address those disparities where possible. That can be really land well with team-based care. And I think also, related to our land acknowledgement, really recognizing the impacts of colonization too, as a so far unnamed social determinant of health, connected to Indigenous cultural safety and humility, looking for clinicians to make meaningful commitment to providing culturally safe care, doing homework on that, and then practicing it, knowing it's an ongoing journey with that cultural humility piece. And it's, on us to work to develop those trusting relationships and keep people coming back for good care. I've got a note that my audio is going in and out, so I'll just move a little closer to my computer and hope that's okay for folks. Also incorporating anti-racist practices, confronting and interrogating those racist structures in healthcare, trauma and violence informed practice. So being familiar with those principles and incorporating them into practice, and again, doing the homework and knowing that that's an ongoing practice. For recovery and self-defined wellness, wanting to always validate individuals' goals in their treatment and care, which may include recovery and or self-defined wellness and what that looks like. Harm reduction, I'm not going to go into detail for this group, but knowing, that's being included in the previous guideline is so foundational to our work, meeting people where they're at and making sure we keep people safe no matter where they're at and what their current goals are. For the integrated continuum of care, looking at a stepped and integrated approach where treatment options are continually offered and adjusted, and just again meeting people where they're at and knowing that there's not one thing that's going to work for people. People may need to try many things. We need to be patient with that, and we need to support people in that process. Comprehensive health management, so looking at people's whole wellness, their whole health, managing other comorbidities, connecting with people with other care that supports their physical, emotional, mental, and spiritual health. Really including family and social circle involvement where possible too, recognizing that people are parts of communities and networks that we can support as well. Thank you.
Okay, thanks, Emma. So I'm going to go through now some of the recommendations made in this guideline and kind of contrast those with some of the 2017 recommendations. If we can go to the next slide. So this is an overview of all of the guideline recommendations. I'm going to go through these one by one, just to kind of explore them or unpack them a little bit. I'll apologize in advance. I'm going to go fairly quickly through this. This is a ton of material. We could spend prolonged amounts of time talking about any one of these, but we do have a lot to get through today. So this is more of an introduction. These guidelines are downloadable. You can review the evidence summaries supporting each of these recommendations, but we'll go through them quickly one by one just to introduce them and offer the opportunity for discussion, hopefully at the end. So 9 of these do refer to pharmacologic treatment, 3 referring to non-pharmacologic treatment, and 1 of them speaking to harm reduction practices. Next slide, please. So our first recommendation, which is similar to 2017 guidelines, is that adults with opioid use disorder should be offered OAT as the standard of care. All of these recommendations are scored according to the grade system. So the quality of evidence supporting the statement was graded as high. The strength of the recommendation is strong. Quite simply, there are very few medications in modern medicine that are as thoroughly studied or as effective as opiate agonist treatment. This is supported by multiple meta-analyses. So this should be a rather non-controversial recommendation and is nothing new from our 2017 guidelines. Next one, please. So recommendation number 2 is a bit of a departure from 2017. So recommendation number 2 states that prescribers should work with each patient to determine which of the following OAT medications, be that buprenorphine, naloxone, methadone, or slow-release oral morphine, is most appropriate for them at that time based on their individual circumstances, goals, and their previous treatment experiences. The quality of evidence supporting of buprenorphine, naloxone, and methadone has been graded as high. Slow-release oral morphine, which is a newer addition to our toolbox, the quality of evidence for this was graded as moderate, but again, the strength of this recommendation is strong. And this is not to say, I just want to clarify that this is moving away from the 2017 guidelines, which rank these as first line, second line, and expert-led only. And instead, it's kind of reframing this as a collaborative decision between a prescriber and an individual based on their circumstances and preferences. But I should also note that this is not intended to equate these medications in terms of their safety and efficacy. They do have different idiosyncrasies, different safety profiles, different evidence supporting their efficacy. It is recognized that buprenorphine continues to have the most the best safety profile of all these medications, while slow-release oral morphine, as you can see here, the evidence supporting its effectiveness, especially long time, is less than the other two options. But it's about recognizing the individual characteristics of these medications and helping a patient find what medication is going to work best for them as quickly as possible. Recommendation number 3, transition between OAT medications should be facilitated if indicated by either clinical circumstances or by patient preference. Again, framing this as a collaborative decision between patients and prescribers. The quality of evidence supporting this statement is low. This is a rather broad recommendation, but again, the strength of the recommendation as graded by the committee was felt to be strong. This is again recognizing that people need different things at different times of their life, and that depending on where they're at and what their individual preferences and circumstances are, switches between these medications are always worth considering. Recommendation number 4, so patients who are stable on between 8 to 24 milligrams of sublingual buprenorphine naloxone may be offered the monthly extended release formulation of buprenorphine if indicated by patient preference and or by their circumstances. So this is a newer addition to these guidelines. This is the addition of extended release of buprenorphine, also known by its trade name Sublocade. The quality of evidence supporting this is low as still a rather new tool in our toolkit. But once again, the strength of this recommendation was felt to be strong. You will note that this is basically referencing the on-label indications for buprenorphine naloxone, and we do explore a little bit about some of the more experimental use of this for people outside of these dose range. But this is a new addition, adding an extended release formulation, which is an option that has the potential to enhance convenience and flexibility and potentially reduce medication burden for some patients. Recommendation number 5, and so this is again a new addition to these guidelines. Recommendation number 5 is states that injectable OAT with diethylmorphine or hydromorphone should be considered for adults with severe opioid use disorder and ongoing unregulated injection opioid use who have not benefited from or who have declined oral options for OAT. The quality of evidence of this recommendation is moderate, and the strength of the recommendation is conditional depending on individual circumstances and locations and infrastructure. But this is a new addition to our guidelines. This is essentially the incorporation of IOT as an option as a part of the standard of care for patients with opioid use disorder, which was previously kept in a separate guideline. So this is just recognizing this as a part of what we feel should be the standard of care for patients with opioid use disorder in the province of BC. Recommendation number 6, opioid agonist treatment should be viewed as an open-ended treatment without any clear timeline on it. However, if a patient does wish to discontinue the medication following a sustained period of stability on OAT, the evidence would suggest best outcomes at 12 months or more. A slow, thoughtful flexible taper should be offered. The quality of evidence behind this statement is moderate, and the strength of this recommendation, once again from the committee, is strong. This is just recommending that, or recognizing that OAT is a long-term treatment, that every individual has their own individual course, but that the best outcomes for anyone who does eventually choose to taper off of the medications do occur if it's done after at least 12 months of stability, and if it's done slowly and thoughtfully rather than rapidly. Recommendation number 7, for adults who choose to discontinue OAT, a relapse prevention plan should be collaboratively developed and implemented after a discussion of both pharmacologic and non-pharmacologic options. So the quality of evidence supporting this statement is low, but again, the strength of the recommendation is strong. This recommendation kind of goes hand in hand with recommendation number 6, recognizing that different people do ultimately choose to taper off of OAT at certain points in life, and that is very much an individual's decision. It is recommended that the longer the period of time on a stable dose vote before a taper is initiated, the more likely a success in completing the taper and remaining abstinent from non-prescribed opioids. The longer the taper and period of stability, the higher likelihood that people will manage to continue on that track. However, rates of return to non-prescribed use are high. So if a taper is decided upon collaboratively, it's important to talk about relapse prevention plans. And that may include non-pharmacologic strategies and supports, and it may include pharmacologic strategies such as PO naloxone as one potential option for those who've tapered off of agonist therapy, or even consideration of strategies for reinduction on buprenorphine, like pill and pocket approaches, should be discussed and discussed on an ongoing basis between patients and providers. Recommendation number 8, oral naloxone is not a recommended treatment for adults with opioid use disorder. However, it may be offered to individuals who have declined or discontinued OAT and would prefer non-opioid treatment. The quality of evidence behind this statement is low, and the strength of recommendation is conditional. Now, there is evidence for oral naloxone in certain special populations and circumstances, but on balance, it has not been shown to perform particularly well as a first-line treatment for opioid use disorder. However, it still is a medication. It is still one of those few tools that we have in our toolkit that can be effective in certain circumstances. As a part of an overall strategy to prevent return to unregulated opioid use, after discussion of all other available options, including things like PRN buprenorphine, oral naloxone can be considered. Recommendation number 9, while extended release naltrexone, known by its trade name Vivitrol in the US, is not currently available in Canada. It is an evidence-based treatment that may be considered for patients with opioid use disorder who are not interested in agonist therapy. The quality of evidence supporting this statement is graded as moderate with a conditional recommendation. Obviously, this is not an option currently in Canada, unfortunately, unless you have patients who are able to go regularly over to the United States and pay out of pocket for extended release naltrexone. It does have evidence supporting its efficacy in the treatment of opioid use disorder, even if it's not necessarily as effective as the standard of care, which is agonist treatment. So this is perhaps an aspirational recommendation, but it's our hope that one day extended release naltrexone will be available in Canada as, again, just another option so that we can provide the best care possible for our patients. I'll turn it over to Emma for the non-pharmacologic treatment recommendations.
Thanks, Paxton. And hopefully my audio is okay here. And we're going back and forth just a bit because there's so many pieces to get through here. So for recommendation 10 for non-pharmacological treatment, the recommendation is, well, it's not a recommendation. Withdrawal management alone, including rapid opioid agonist tapers without transition to OAT, is not recommended. The quality of evidence here is moderate and the strength of recommendation is strong. I think many of us have seen in clinical practice, unfortunately, when people do taper off, relapse rates are quite high. And we just know with the toxic drug crisis that can be incredibly dangerous for folks. Again, Paxton went over ways we want to always be supporting individuals with their goals, but this guideline does not recommend withdrawal management alone. And go on to 11. So also for non-pharmacological treatment, if the patient chooses to pursue withdrawal management, this should be conducted ideally in an outpatient setting, followed by a collaboratively developed relapse prevention plan and referral to long-term psychosocial treatment and support. Again, yeah, really just bolstering and shoring up resilience and strengths and support and the social determinants of health for folks. In these cases, a really slow taper as well in an outpatient setting seems to yield better results. The quality of evidence for this one is moderate. The strength of recommendation is strong. And yeah, keeping the door open for folks who want to come back. For recommendation 12, psychosocial treatment interventions and supports should be routinely offered to adults with opioid use disorder in conjunction with the pharmacological treatment. Quality of evidence for this one is moderate, and the strength of recommendation is strong. And yeah, this is just really, again, tending to those other pieces of wellness for folks, the other pieces that hold them up in areas of their life. But we also want to just note that if people do not want to participate in those pieces, that should not delay or hold up their treatment with OAT at all. And then for recommendation 13, this is around harm reduction. So conversations about safer drug use, take-home naloxone, and referral to other harm reduction services should be routinely offered as part of standard care for individuals with opioid use disorder. Quality of evidence for this one is moderate, and the strength of recommendation is weak or conditional. Looking, to clinicians to routinely offer information and education about harm reduction resources and safer use practices, including safer consumption supply distribution programs, take-home naloxone, overdose prevention sites, supervised consumption services, and drug checking services. So yeah, really wanting to hold up those pieces as well. And I'll just pause here before going back over to Paxton, just to again thank folks. We continuing to see folks rolling in to join this webinar. So thank you for taking the time to connect here today.
Can I just jump in quickly before we go to Paxton? I just want to emphasize that all 13 of these recommendations are predicated on the involvement of the patient, and no assumption should be ever made. If you're the doctor, listen, and let's have two-way conversation, not tell the patient what you think is good, whether it's a weak recommendation or not. The patient is the ultimate decision maker. And so as I say, I think all 13 of them predicated on the fact that you involve the patient from the word go. And as long as I've been very successful myself on OAT because of that good discussion I've been able to have with my doctor. And I'm the happiest camper in the world at the moment.
Thanks, Dean. Yeah, I really hope that idea of collaborative decision-making really cuts through this entire document. So that was a whirlwind tour of the 13 recommendations. Those are rather high level, and each does come with a thorough review of the evidence in those respective areas in the document itself. Lots to talk about there. But the other piece of this document that I think is so important and hopefully of interest to the audience today is the specific clinical guidance recommendations that are made. Especially the changes here compared to the 2017 guidelines. So we're going to go through a non-exhaustive list of all of those clinical guidance updates, some of the more important, relevant updates. Where possible, I'll make reference to the data supporting these decisions. I'll say that much of this is based on expert consensus, and there's actually not a tremendous amount of data to inform much of these, but thanks to the tremendous committee of experts from around the province that we were able to assemble, we were able to make some iterative but pretty significant changes to our clinical guidance recommendations. So starting with buprenorphine naloxone. So we made some updates to dosing and titration recommendations around buprenorphine naloxone, starting with a recognition that the maximum daily dose for both traditional and for low-dose inductions, or for maintenance with buprenorphine in general, has been increased in these guidelines up to 32 milligrams. The label in Canada suggests 24 milligrams as the ceiling dose for buprenorphine, but increasingly, especially in the current era, there's recognition and pretty good data to support the fact that higher doses retain people better and longer. And so increasing that maximum daily dose to 32 milligrams for buprenorphine naloxone is reflected in these new guidelines. Perhaps more importantly, the day one maximum dose for traditional inductions is often described as 12 or 16 milligrams as a maximum dose on day one. There is a recognition, again, that's based on the product monograph, but there's a recognition in these guidelines that higher doses may very well be necessary on day one if withdrawal symptoms persist. And if somebody is continuing to experience withdrawal, despite being on 16 milligrams on day one, then continue to increase their dose as needed until those withdrawal symptoms are resolved. There's no firm ceiling on day one. A second addition as far as dosing and titration of buprenorphine naloxone goes is the inclusion of low-dose inductions, also known as micro-inductions, which are, as many people are aware, are a novel form of starting people on buprenorphine, which has become quite popular since the 2017 guidelines came around. This may be a preferred induction method for people who are currently using fentanyl or other intermediate or long-acting opioids. And the principle is quite a simple one, which is rather than a rapid initiation on a single day, to slowly uptitrate small doses of buprenorphine incrementally over a period of time without cessation of other full agonist opioids until a therapeutic dose has been attained, and that often maybe 3, 5, 7, or even 10 days. This would be an example of a sample 7-day low-dose induction protocol, which is included in the guidelines. This is a relatively common approach. I would stress that there's no formally recognized induction protocols. These need to be tailored to any individual patient's preferences and circumstances. But the benefits of these low-dose inductions can be tremendous for some patients in that they don't require that preceding period of withdrawal. They may reduce the risk of precipitated withdrawal. They can be started on day one in the clinic or take-home doses, and co-prescribing of a full agonist such as methadone or slow-release oral morphine may be considered in combination with the low-dose induction until they achieve a therapeutic dose of buprenorphine in order to reduce the reliance on an unregulated drug supply during the induction phase. Last thing I'll say about that is just there is very little evidence supporting best practices as far as low-dose inductions go, but they become increasingly common. So that was largely influenced by the clinical expertise of our group. As far as traditional inductions go, they are certainly still a potentially recommended practice. I mean, and I think it's important to discuss with an individual patient which induction strategy best meets their needs and their preferences. But there is I think we skipped can you go back one? Yeah, there. So, but traditional inductions are still included as an alternative approach that still can be very effective for many. There is some adjustment in our recommendations around this. As many of you know, we usually employ the COWS score to help determine when a sufficient amount of time has gone by whereby somebody can tolerate buprenorphine and feel better rather than going to precipitated withdrawal. COWS is still included, but in addition to that, there's also a recognition that for longer acting opioids, sometimes COWS is not completely reflective of when a safe window to start these medications are. So for somebody who's using short acting opioids like heroin or oxy or hydromorphone, an appropriate COWS score in more than 12 hours since the last used opioid is still considered an appropriate time to start the traditional induction. For those who are using intermediate acting opioids like slow release oral morphine or fentanyl, which may be a short-acting opioid, but is very lipid-soluble and therefore has a longer half-life in those who are using it more frequently. A 24-hour period is recommended between last use and initiation of buprenorphine, even if an adequate COWS score has been achieved. So this is a novel addition. This is a reflection that even at 24 hours in the literature, waiting out to 48 hours is still your highest likelihood of limiting risk of precipitated withdrawal, but obviously that needs to be weighed against what is achievable by individual patients. And for those who are long-acting opioids like methadone, 48 to 72-hour washout phase is recommended before a traditional induction. Should precipitated withdrawal occur, as it unfortunately will if you start enough people on buprenorphine, there's been some reframing of the potential approaches for managing that. So option one is to continue the induction as traditionally laid out, continuing to give 2 to 4 milligrams every 1 to 2 hours and assessing COWS scores. Option number two, if feasible, depending on your setting, could be to delay an induction. So if they choose to continue after experiencing precipitated withdrawal, to wait for a number of hours to let the opioid receptors clear to let whatever other opioid is present wash out, offer non-opioid adjuncts to help bridge that gap, and then opt to continue up to the day one maximum or until withdrawal symptoms are resolved. Both of these are consistent with what was already in the 2017 guidelines. Stopping the induction entirely, also in the 2017 guidelines, and always an option. The fourth option is the new option here, which is based off of increasing clinical experience, although there's very little data to actually support how best to do this, but it's becoming an increasingly popular option for those who do experience precipitated withdrawal, is to try and essentially push through it with more buprenorphine. Buprenorphine is an opioid agonist, even if it's a partial one, and at sufficient doses it can resolve precipitated withdrawal, although there's always a certain risk with giving more buprenorphine on top of withdrawal, that you may make the withdrawal worse and not better. If you do decide to push through with high-dose buprenorphine, it's recommended you have a conversation with your patient and make sure that they're consenting to this and recognizing that it may be the fastest way to make them feel better, but they may feel worse first, and then give high doses, typically ranging from 8 to 24 milligrams at a time, to try to resolve those withdrawal symptoms. Next page. Once again, I'll say that all of those are based on clinical expertise, and there's little evidence to inform any of those which approach might be best for any individual circumstance. Missed dose protocols for buprenorphine and naloxone have been refined slightly. We distinguish with return to full agonist use, so presumably non-prescribed use, although it could include prescribed full agonists as well, versus those without a return to full agonist use. For those who have discontinued buprenorphine and returned to full agonist use, less than 3 days or less of missed doses, the suggestion is to continue the buprenorphine naloxone without reinduction based on its half-life. There should be sufficient bupe left in the system to prevent or reduce or limit the risk of precipitated withdrawal. With 4 days of missed doses, discussing risks and benefits of continuing at the same dose versus reinduction. The risk of precipitated withdrawal does start to increase after 4 days of missed doses with return to full agonist use. And with 5 or more days, it's suggested that a new induction may be required. Most, if not all, of the buprenorphine will be washed out of their system at that point, and they will likely require a new induction, whether that's through a low dose or traditional induction approach. There's a key practice change here for pharmacists, just that if somebody does miss 4 consecutive doses of buprenorphine and are on daily witness dosing for some reason, which is increasingly unusual, and I'll speak to that later, that a script will be canceled at that point, and a new induction may be required. To complement that, for those who have missed doses of buprenorphine naloxone without any return to full opioid use, up to 5 days of missed doses, they can safely continue the buprenorphine without any dose reductions or adjustments. With greater than 5 days, a retitration is suggested, starting at a lower dose and titrating up until symptoms have been adequately treated. As far as dosing and titration goes, again, as we mentioned, extended release buprenorphine is a new inclusion in these guidelines. As per the label on extended release buprenorphine, patients are recommended to be started and stabilized on sublingual dosing between 8 to 24 milligrams for a minimum of 7 days. So that is the product monograph for extended release buprenorphine in Canada. Although there is some exploration of early data around more rapid titrations and transitions that are gaining popularity and are certainly reasonable in the appropriate clinical circumstance. The starting dose of extended release buprenorphine is 300 milligrams Q4 weeks for the first 2 months, beyond which a maintenance dose of 100 milligrams from 3rd month onwards is recommended. Again, according to product monograph, there is a recognition that for some, a maintenance dose of 300 milligrams might be preferable. And so that's an individual collaborative decision, again, to make with the patient, depending on their individual circumstances. Just one note that this is also on the product monograph and is a relatively recent update to the monograph in Canada, that those who are maintained who are sustained on a 8 to 18 milligram sublingual dose for a period of time, i.e. they don't require quite as high serum levels of buprenorphine, they can transition to the 100 milligram maintenance dose after a single 300 milligram dose, and that's based on data and is reflected, or that's based on modeling primarily, and is reflected in the product monograph. Next slide. As far as missed doses for extended release buprenorphine, it's rather straightforward. The administration window for this this medication is 26 to 42 days. As per the product monograph. So beyond, if you've missed your dose by more than 2 weeks, a reinduction may be warranted. And so somebody could be restarted on sublingual, titrated up to a therapeutic dose, and then transitioned quickly to extended release buprenorphine. I will say that there's, based on what we know about the pharmacokinetics of these medications, there's quite a bit of potential wiggle room here. So if you do have these patients and you're not comfortable on how to proceed, you can always call the 24/7 or the race line, and we can talk through it, because this is the product monograph. There is quite a bit of opportunity for some flexibility in here. So perhaps more that is most of what we're going to say about buprenorphine. There's some small changes there, some iterative changes. There's some important ones. Much is, I think, reflective of current practice in many parts of BC. Now we're moving into the full agonists, and this is where things get a little bit more interesting. I think a bit more. I think the changes are more consequential. So as far as dosing and titration goes for methadone, there has been a change made here. As many of you are aware, our 2017 guidelines, as to most Canadian guidelines, recommended a starting dose of no higher than 30 milligrams. And that's typically based on sort of 3 categories of risk: no tolerance to opioids, moderate tolerance to opioids, and high tolerance to opioids. There is a recognizing that increasing doses of methadone are needed in the context of fentanyl and a really potent drug supply, and recognizing that people are retained better with higher doses and with more rapid titrations, and recognizing that that attrition tends to be very high at these starting doses. We have recommended starting doses of up to 40 milligrams of methadone for patients with a history of methadone experience in the past and documented current fentanyl use, who are actively using fentanyl at that point in time. Many people may say that this may be insufficient, and that even higher doses are required, and certainly that's something that we've heard from our colleagues with lived experience. This is based on the best available data we have anywhere, essentially in the world, which does describe some safety to starting doses as high as 40 milligrams on day 1, but really doesn't extend beyond that. So this is the strongest recommendation we could make based on existing data, although there is a recognition within the guidelines as a whole that clinician experience can weigh in here. It's just this is the highest evidence-based starting dose that we could really endorse. As far as titration goes, another small but quite significant change that, again, for those who are deemed to have high opioid tolerance, i.e. history of fentanyl use, that rather than our traditional 10 milligram increases every 3 to 5 days, that they may qualify for increases of up to 15 milligrams every 3 to 5 days, at least for that induction phase. At approximately 85 milligrams, which is starting to enter what is classically defined as a therapeutic range, it is suggested that slows down somewhat to 10 milligrams every 3 to 5 days, but there is some room for some clinical discretion there. For those with lower tolerance who are not using fentanyl, using more traditional opioids, whether it's heroin or prescribed opioids, doses should still be increased a little bit more cautiously, 5 to 10 milligrams every 3 to 5 days. We also recognize that the traditional therapeutic range, which is often 80 to 120 in the literature, may not necessarily apply to those who are fentanyl tolerant, and higher doses are often needed. Moving to slow-release oral morphine, our other full agonist treatment. Similarly, a starting dose of beyond 200 milligrams, which is sort of become the standard starting dose, even if that's not what was reflected in the 2017 guidelines. There is recognition that for those with very high tolerance to opioids, i.e. documented exposure to fentanyl, and with a history of being on SROM in the past, that starting doses as high as 300 milligrams can be considered, which is analogous to the 40 milligram starting dose of methadone. And similar, and dose increases, and again, this is mostly reflective, I think, of the standard in BC, although it's still an update to the 2017 guidelines, that dose increases of up to 100 milligrams every 24 to 48 hours are endorsed in these guidelines. To be clear, there's no defined maximum dose for SROM. It's just recognized that doses beyond 1200 milligrams have never really been described in the literature. We know that there can be safety issues with morphine and its metabolites at higher doses, and it's just something to be conscious of and watching for those who are on exceptionally high doses of SROM. A key practice change I'll highlight here for pharmacists is that open and swallow is no longer the default for SROM. This is recognizing the sheer number of capsules and of pellets that are people being asked to swallow, and the we've heard loud and clear that this is a problem for patients. It's also a great deal of work for our pharmacists. So the default is now to provide SROM as a capsule to be swallowed whole, unless specifically clinically indicated or ordered by the physician or preferred by the patient himself, where open and sprinkle can still be an option. Missed dose protocols is another. So I should say that one of the themes of these guidelines we're looking at all the areas of being on maintenance therapy where patients have identified the patients have been identified as problematic or as a burden, and missed doses and missed dose protocols and dose reductions has been clearly identified as a huge barrier by many of our patients. So we have updated our missed dose protocols to somewhat for methadone. So for methadone, we've aligned with actually missed dose protocols in Ontario, where up to 3 missed doses of methadone can be permitted or tolerated before dose reductions are needed to be made in the name of safety. For slow release oral morphine, we've aligned those missed dose protocols with methadone. We've looked at the pharmacokinetics and the evidence behind missed dose protocols for both these medications, and decided to harmonize missed dose protocols to be the same between the two medications. So if 1 to 3 doses are missed, no change is needed. With 4 missed doses, a prescription will be canceled by the pharmacy. A patient must be reassessed, and they can be safely restarted at 50% of that dose. And with 5 or more, a prescription is canceled and a titration must be restarted. Moving in to the next slide, just recognizing there's a few slides left for Emma, and then we'll move into Q&A. So I'll turn it over to Emma to talk about take-home dosing, the last big change.
Thanks, Paxton, and so much information to cover. Again, there'll be lots of resources I'll mention in a few moments too that kind of encapsulate all this. So one of the things I'm most excited about, the relaxed take-home dosing guidance, hopefully if we're able to make just much more reasonable attendance to pharmacy schedules for people, we won't need to be restarting people or retitrating folks if they're able to just stay on their medications in a much more reasonable way. So for buprenorphine, naloxone, looking at take-home dosing being considered immediately for people who are able to safely store their medication and who demonstrate some clinical and psychosocial stability, which is sort of generally looking at ability to attend appointments, absence of severe mental health crises or severe behavioral issues or severe sedation or very high-risk substance use patterns, wanting to emphasize that people experiencing homelessness can absolutely be considered for take-home dosing, and that people who continue to use substances also be considered for take-home dosing. So really not requiring that abstinence in order to earn take-home doses. And in fact, we may be able to support people to meet their goals if they're actually able to have much more flexible medication schedules. So for methadone and SROM, the take-home dosing criteria for those two has been aligned. Again, emphasizing total cessation of non-prescribed substance use not required in order to be able to have those take-home doses. And take-home methadone and SROM doses generally starting as individual non-consecutive carries, so 1, maybe 2 days at a time. For people who meet that dosing criteria, and then offering additional ones gradually. So folks able to demonstrate managing those previous take-home doses, consistently taking their medication, and a general improvement in wellness. Again, clinical discretion may dictate faster take-home doses, and also wanting to recognize that in many, less urban, more rural settings, there is no pharmacy access, and so practitioners have already been having to do this just simply to have people on OAT. And so now there are guidelines that support those practices. So to go over who may or may not be a candidate yet for take-home dosing. So again, looking at that ability to safely store medication, people who are quite unstable, missing doses or appointments, or having an acute mental health crisis would probably not be a current candidate. Or really, really high risk or uncontrolled substance use patterns. for those initial non-consecutive take-home doses, ideally looking at a minimum time of 4 weeks. However, knowing that, in some cases that may need to come a little bit sooner, ability to safely store medication, and that stability I mentioned as well. And then for the more and consecutive take-home doses, looking at perhaps a minimum time on methadone or SROM for 12 weeks. And again, those continued improvements. And so we know this is like quite different than perhaps previous practice. And I think, Dean again spoke to really wanting to see these practices hopefully be taken up equitably everywhere so that people have this good access. Also noting that this dose guidance aligns with the Medify guidance that Paxton already mentioned, and that these take-home doses may come earlier in some cases. And this is just another summary again. So I think we can go to the next slide. There was a urine drug testing breakout resource that already came out, some excellent shifts in practice, and now those are embedded right in this guideline. I think this is really important as practitioners, as someone who's collected hundreds of urine drug tests, knowing that it's a really challenging part of care for some people. And this is a real opportunity for us to sort of shift how we do this, how we talk about it, and some of that stigma that patients can experience. So really only looking at it, performing it when the results may impact the treatment plan. So not just doing them for the sake of doing them. There are no minimum number of required UDTs per year, which used to be part of guidance. And then the purpose of UDT should be discussed with people, including how unexpected results will be addressed and how those may affect the treatment plan. Only doing confirmatory testing when results, again, would change clinical management. So really just being very specific and objective around how we're using urine drug tests, how we're talking about them. They should be scheduled, not random. They should be collected using supervised urine drug tests and never witnessed. Very stigmatizing practice. And a negative urine drug test for other opioids or substances is not required to be considered for take-home dosing. There is a number of supplements for specific populations and settings that you can check out in the guideline. And yeah, so in summary, really, we can go to the next slide for this. Yeah, as Dean said, that it's all collaboration. We've moved away from ranking out medications, just recognizing people may need to try different things, and it's, whatever is going to work for that person at the time. And, these are just a summary of what we've gone through. I'm just wanting to leave time for questions. There's some great resources where the huge guideline has been condensed into some more accessible bite-sized resources. So the next slide, I'll just show a couple screenshots of those. And then there's also some really interactive resources for mobile devices. And again, obviously highlighting the 24/7 line, accessible to practitioners and also people working addiction support staff in First Nations communities as well as who are listed here. Thank you so much.
Thanks so much, Emma. And thank you to the panel, Dean and Paxton, for going through that. I want to acknowledge this is a lot of information. And so just as highlighted in the chat, this will be recorded. It will be sent out to all the registrants in this session. And then we also will be distributing it on our YouTube page. And also through our Echo and provider blasts as well. So you can watch these wonderful faces whenever you want, talking about this exciting guideline. I wanted to make sure that we were able to get through all the slides, so I apologize that we won't be able to get to all your questions, but we are recording these questions too, so we can follow up with some of them. I'm going to put forward a couple of questions to the panel here. And because this one was asked a few times, I'm wondering if the panel can elaborate a bit here. So there's a question about, can you be a bit more specific about what does ability to safely store medication mean in the context of homelessness or staying in a shelter? So essentially just what is required or what considerations would you make around that?
Yeah, I mean, I can start with that one and see if Emma has anything to add. I think one of the realities of these MISTOS protocols are quite a significant change, and I think for the better. As I mentioned, they are aligned with changes that have gone live in Ontario as a couple of months ago, and this is one of the only changes to the clinical guidance that's actually based on a pretty significant body of evidence that's emerged during the context of COVID-19 and changed to take-home dose protocols over that time. So one of the realities is that this opens the door for a lot more clinical discretion around what is clinical stability such that somebody can take care of their medications, or what is the ability to safely store their medications. It's not quite as black and white, for better or for worse. I would argue for better than our previous guidelines. So it really is up to your individual judgment. If somebody was homeless, sleeping on the street, unsheltered, I would have real concerns about their ability to safely store their medications. Really real concerns for them that they're not going to get their medications stolen from them. If somebody's staying in a shelter where they have access to a cabinet that locks on it, it's a very different story. So I think it's really about discussing with an individual what their plan is, and if that feels safe and appropriate to you. And there is that element of discretion that's built in.
Thank you, Paxton. Anything from Emma?
Yeah, I think just to reiterate, having that conversation about their situation and really making that patient-centered.
Right. There was also a question about, has the clinical update been vetted by the College of Physicians? And can clinicians be assured that they won't be tagged for the prescription review program, or can clinicians lean on these guidelines if they are flagged by prescription review for practicing in accordance?
As of November 22nd, this is live. It has been reviewed by the College of Physicians, the College of Pharmacists, and the College of Nurses and Midwives. Actively just trying to disseminate this information. Whether or not your local pharmacist is aware of these MISTOS protocols and is going to, the uptake is going to vary. But this is live, and this is now considered the standard.
Thank you, Paxton. And I will also make a note, just that on our website, on the Opioid Use Disorder Guideline page, there's a ton of resources, learning materials, a friendly web app resource that has summaries. And I think that, like, while we will do webinars and continued education to help with the change management, these tools were designed to also help support change management in your different communities. Some of the resources are for rural remote as well. So I just want to put a shout out to that, because there have been questions about, are pharmacists aware, are different clinicians aware? And we will be having a pharmacist specific webinar as well. Second question, or sorry, not second, another one. So can you please just take a moment to re-highlight the differences in take-home dosing between buprenorphine and methadone and Cadian? Like, what are things, I guess, that you would highlight to pay attention to?
Can you take that one, Emma?
Oh, sorry, I thought you were going to take it. Yeah, we, looking at, it's really the biggest difference is that for buprenorphine and naloxone, you could be considering that the first time you meet someone. And so that can be a consideration much quicker, again, just due to that higher safety profile that makes it easier to make that decision. With SROM and Cadian, those are aligned with each other as full agonists. And usually you have more relationship, you've been seeing someone for longer, but it just so it's a slower schedule in terms of increasing those, but we're looking at the same criteria for people in terms of that ability to safely store medications and that increasing clinical and psychosocial stability. So those criteria don't differ between the medications. It's more how quickly you'd be looking at take-home doses or increasing the take-home doses. You want to add anything, Paxton?
No, just, yeah, exactly that. And just the fact that, again, there's some clinical judgment involved here. So it's about risks and benefits, and risk to the patient and those around them. Suboxone, really an incredibly safe medication, one that is where the consequences of somebody else accidentally taking it are far less significant than with methadone or slow release oral morphine. So I think there's that opportunity for clinical discretion, and that's and collaborative decision making with patients.
And then with that, decision making, if it's, you know, your first time doing it, and you're wondering about it, call the 24/7 line if you don't have anyone else to talk about that with. So yeah, talk to someone else about it if you're kind of wondering about how to make that decision.
Thanks so much, everyone. I'm sorry I have to cut us short. It is almost 1 o'clock. If you haven't had a chance already, please complete our post-webinar poll. We care about what you think. We care about your experience. We do take these notes. I want to thank Dean, Paxton, Emma, Mona for being a part of our panel. Mona, I love the Christmas tree in the back. We will be taking copies of the Q&A, so we can also follow up with some of those questions that we weren't able to answer. And then I want to thank Liz, Cora, and Lindsay for doing all the back end work of getting us organized. Thank you so much. And we will be connecting and follow up with these new guidelines. So stay tuned as you know, we help spread some of the updates and evidence. So thank you all. And then if the panelists, if you don't mind hanging on while we end the session, just for a short debrief. Thank you.